like to invite our 4 speakers back up to the stage, and we have time for a Q&A. So think about some questions that you might want to ask, and you can ask any of our 4 speakers to answer your questions.
I have a question with reference to breast reconstruction. I did have double mastectomy, but I was apparently not a candidate for reconstruction because I did have liposuction about 10, 15 years ago. What are your thoughts on that?
Is this on? So that's a rather controversial area. So I do agree with the assessment from your plastic surgeon that generally speaking, if you have undergone liposuction, that's considered surgical intervention to your abdomen. So using abdominal tissue would not be considered a first option for reconstruction. That being said, there are other parts of your body where if you have redundant tissue, so for example, the second most common area that we can take tissue from is from your buttock or from your inner or outer thigh. So if you do have redundant tissue there and there hasn't been any surgical manipulation in the past, then you could be a candidate using those tissues.
We have a question over here.
What are the risks of reconstruction in the abdominal fat method, and what's the success rate?
So that's a good question, and I'm happy that you're answering that, or that you're asking this question. I'd say that about 5 years ago, we would tell you that there was higher complication rate, higher failure rate. But today, if you go to most institutions where they perform higher volumes of this type of surgery, we will tell you that the failure rate, so that if it doesn't survive, is less than 1%. So less than 1 out of 100 women who undergo this type of surgery will have a failed reconstruction. There are, of course, other complications that are common to surgery in general, like bleeding, having a fluid buildup, or infection. But those are what we call modifiable or amenable complications where we can treat them.
Yes.
Hi, thank you guys so much for talking. I was just wondering about the program that you were talking about for young women who are at high risk. I was wondering if you have to already have been assessed at high risk and get like a referral from your doctor, how do you go about connecting young women, especially in the I don't know what risk I am at kind of category?
So some family physicians know how to run an IBIS risk calculator, and they will have looked at your personal family history and have completed that and faxed it in. That requisition, as I mentioned in the presentation, you can upload that from the Cancer Care Ontario website, and your family doctor can fill it in. And if you have a strong family history, preferably if you have women that are under the age of 50 and have had breast cancer or breast and ovarian cancer, and then we would send that referral to our genetics counselor to do a telephone consult with you first. And if you qualify at that point for genetic testing, then they will bring you in person to discuss that and organize that test for you. So if you are deemed eligible, then we would enroll you into the program, and we would start your breast imaging for women that are menstruating during days 7 to 13 of the cycle, and for those that don't menstruate, we capture it at any time. And I would like to emphasize that that's important because for women that menstruate, there are particular times in the cycle where the hormone levels are very high, and if we screen at that juncture, there's a higher risk of false positives on the imaging. So we do it when the hormone levels are at the lowest level.
Yes.
My genetic test came back inconclusive. So where do I go from there?
So how long ago did you have your genetic test? Okay, so it was 2013. I would go back to your genetic counselor. Inconclusive means that maybe there wasn't enough information at that time about that particular variant that you were identified as having. we're always updating our information. I would go back to your genetic counselor to see if there's any updated information about that variant, and to see whether or not you qualify for any other type of genetic testing.
We have a question here.
Actually, two quick questions. I wanted to ask about breast reconstruction after radiation. And also I wanted to ask if the high-risk program is open to women who've had breast cancer under the age of 30.
So if a woman has had a breast cancer under the age of 30, those women are often referred to our genetics to rule out that there is a gene mutation. And once they've completed treatment, if their lifetime assessment score is 25% or greater, then absolutely they can be referred, and they continue having high-risk surveillance through the high-risk program with mammograms and MRIs. Or if the MRI is contradicted for other reasons, such as metal in the body, or they have poor kidney function, then we would do bilateral ultrasounds with the mammogram screen.
So to answer your question, it is possible to have breast reconstruction after you've had radiation treatment. We generally recommend waiting at least 6 months to, most cases, about a year following completion of radiation. Now, that being said, the options available for reconstruction are more limited than if you have not received radiation, but it is still possible.
And we have a question from social media.
So this woman asks, I think this would be a question probably for Shelley. She would like to get your opinion on other methods of screening that are coming out, such as thermo, blood tests, and the breast cancer bra she cites. And she asks, what should we be keeping watch for coming in the future of screening?
So thermal screening is actually not a very good tool to screen women deemed at high risk. We do mammography and MRI because they are the best tools for women deemed at high risk of capturing early aggressive cellular changes. And our goal is to prevent cancer and catch them when they're either an atypical change where the surgical and treatment interventions are less invasive. In terms of other treatment modalities that she was asking, you were asking about blood testing. So again, that would go back to our genetics for genetic testing to see if there's any gene mutation that they could be predisposed to. And having clinical breast examinations every 6 months done by the family doctor or in conjunction with the family doctor and a high-risk physician.
That's all the time we have for questions, but it was a real treat for all of us.